By age 65, more than 75% of physicians in lower-risk specialties and 99% in higher-risk specialties will be sued for medical malpractice. That's not a projection. That's a claims analysis of over 40,000 physicians published in the New England Journal of Medicine. But here's what that statistic doesn't tell you. It doesn't tell you about the physician who stopped sleeping 3 months into discovery. It doesn't tell you about the surgeon whose hands start shaking before a case, not from age or disease, but from the weight of knowing that every decision he makes could become the next line in a plaintiff's complaint. And it doesn't tell you about the otherwise healthy spine surgeon who died of a pulmonary embolism during his own malpractice trial. Today, we're starting a 3-part series on something the medical profession has been whispering about for decades, but has never adequately addressed. It's called Medical Malpractice Stress Syndrome. And this is part 1, the syndrome. Medical Malpractice Stress Syndrome, MMSS, was first described in the 1980s by a psychiatrist named Sarah C. Charles. Dr. Charles was a professor of psychiatry at the University of Illinois College of Medicine in Chicago. In 1976, she endured a 6-week malpractice trial in federal court after a patient attempted suicide. The jury returned a defense verdict. She was found not negligent. But the experience of that trial changed the trajectory of her career. She would go on to spend the next several decades studying what happens to physicians, psychologically, emotionally, and physically, when they're named as defendants in malpractice litigation. Michael, before we get into the clinical evidence, I want to ask you something. When did you first hear about MMSS?
Honestly, not during medical school, not during residency, not during any orientation or CME course I've ever attended. I first encountered the term when I started studying health law, which tells you something about where this knowledge lives. It lives in the legal and medical legal literature, not in clinical training. And that's a problem, because this is a condition that will affect the majority of physicians at some point in their careers. We teach medical students about burnout. We teach them about compassion fatigue. We talk about wellness, but we don't teach them about what happens to their mind and their body when a process server hands them a summons. And I think that silence is part of what makes MMSS so destructive.
Dr. Charles's research formalized the concept. In comparative studies, she found that 86% of physicians who had been sued for malpractice experienced significant anger, compared to 46% of physicians who had never been sued. And 79% of sued physicians reported depressed mood, compared to 50% in the non-sued group.
Those aren't small differences. That's a 40-point gap in anger and a nearly 30-point gap in depression between sued and non-sued physicians. And this was pioneering work. She was the first person to actually quantify what every sued physician already knew in their bones, but didn't have language for. She gave it a name. And naming something matters because until you name it, people suffer alone and think there's something wrong with them specifically. When you name it, it becomes a recognizable occupational hazard. It becomes something you can study, measure, and intervene on.
In 2017, Paterick and colleagues published a paper in the Journal of Medical Practice Management that formally characterized MMSS as a, and I'm going to use a medical term here, a forme fruste of post-traumatic stress disorder. Sarah, can you explain what that means in a legal and clinical context?
A forme fruste, the term is borrowed from dermatology originally, describes a condition that presents as an incomplete, attenuated, or atypical form of a more fully recognized disorder. In this case, MMSS is being described as an incomplete form of PTSD. Physicians experiencing MMSS may not meet the full DSM-5 diagnostic criteria for post-traumatic stress disorder, but they exhibit a substantial subset of PTSD symptoms. And the trigger isn't combat or a natural disaster. It's being named as a defendant in a malpractice lawsuit. This classification matters for a specific reason. Under the DSM-5, PTSD requires what's called Criterion A exposure: actual or threatened death, serious injury, or sexual violence. A malpractice lawsuit, technically, doesn't meet that threshold. It's a financial and reputational threat, not a physical one. But the symptom profile, intrusive thoughts, hypervigilance, avoidance behavior, emotional numbing, sleep disruption, maps almost directly onto the PTSD framework. That's why the Form Frust label is so useful. It acknowledges the clinical reality without forcing it into a diagnostic box that doesn't quite fit.
And that mismatch between what the DSM technically requires and what physicians actually experience is part of why MMSS gets underdiagnosed and undertreated. If you're a physician and you're having intrusive thoughts about a deposition, if you're lying awake at night rehearsing what you should have said, if you're flinching every time a patient mentions a complication, you might not recognize that as a trauma response because we've been trained to think of PTSD as something that happens to combat veterans and assault survivors. Not to us, not from a lawsuit, but the neurobiological reality is that the stress response doesn't care about the DSM's criteria. Your hypothalamic pituitary adrenal axis doesn't distinguish between a mortar round and a summons. Prolonged, uncontrollable stress with social and reputational consequences activates the same pathways.
The clinical literature describes MMSS across 3 domains: psychological, somatic, and behavioral. Let's walk through what the research shows. On the psychological side, the most recent comprehensive review, Kokiarale and colleagues, published in Emergency Medicine Clinics of North America in 2024, describes depression, anxiety, shame, guilt, loss of professional confidence, feelings of isolation, anger, intrusive thoughts, hypervigilance, difficulty concentrating, and in severe cases, suicidal ideation. A narrative review by Cruchage and colleagues in 2023 mapped these symptoms directly against the PTSD symptom clusters: intrusion, avoidance, hyperarousal, and negative alterations in mood and cognition. A study at Taichung Veterans General Hospital in Taiwan quantified the burden using the Impact of Event Scale Revised and the Stanford Acute Stress Reaction Questionnaire among 98 medical staff involved in malpractice disputes. 79.6% reported intense frustration, and 72.4% reported severe tension. The highest scoring psychological construct was intrusion, the uncontrollable, distressing replaying of the adverse event.
Intrusion is the one that, clinically, I think is the most insidious because it doesn't respect your schedule. You're rounding on patients at 7 a.m., and suddenly you're back in the deposition room. You're having dinner with your family and you're mentally composing a response to an allegation in the complaint. You're in the middle of a procedure and a thought flashes through your mind. What if this goes wrong too? That's not distraction. That's not being unfocused. That's your brain doing exactly what it does after trauma, replaying the threat over and over, trying to make sense of it, and it doesn't stop just because you need it to.
On the somatic side, and this is where it gets particularly concerning, physicians in active litigation report insomnia, fatigue, changes in appetite, gastrointestinal symptoms, headaches, and cardiovascular manifestations, including hypertension and tachycardia. The Taiwan study found that over 76% of affected staff reported severe fatigue, 71.4% reported generalized tiredness, and 55.1% reported chronically tense musculature. The behavioral changes are equally significant. Vizcaíno-Rakosnik and colleagues conducted a telephone survey of 282 physicians with malpractice claims. both open and closed, and found that 45.4% acknowledged practice changes after being sued. Those changes included viewing patients as potential plaintiffs, paying more attention to record keeping, ordering more tests, avoiding specific types of patients, and avoiding specific procedures. And critically, physicians who reported a psychological impact from the litigation were significantly more likely to adopt defensive medicine practices.
I want to pause on that behavioral piece because it connects to something every physician listening to this will recognize. When we talk about defensive medicine, it's usually framed as a policy problem. Unnecessary testing, higher costs, resource waste, and it is those things. But what it actually feels like from the inside is a fundamental change in how you see the patient in front of you. The patient stops being a person you're trying to help. They become a potential threat, and that's a terrible place to practice from. It's terrible for the patient and it's terrible for you, because medicine is supposed to be about trust, about the therapeutic relationship, and MMSS corrodes that from the inside out.
One of the most important findings in the MMSS literature is that the psychological impact of being sued does not depend on the outcome of the case. Vizcaíno-Rakosnik and colleagues found no statistically significant difference in psychological impact between physicians with open claims versus closed claims. And, this is critical, no significant difference between claims closed with a payout and claims closed without one. The p-value was 1. It was identical.
That finding has enormous implications. The legal system is built on the assumption that the outcome matters, that a defense verdict vindicates, and a plaintiff verdict or settlement reflects fault. But the evidence shows that from the physician's perspective, the process itself is the traumatic stressor, not the result. A physician who wins at trial has still endured 3 to 5 years of depositions, document production, expert testimony challenging their clinical judgment, and the ever-present knowledge that their career, reputation, and finances are at risk. The defense verdict doesn't erase that experience. And the data on defensibility reinforces this. An analysis of over 8,000 closed claims from New Jersey found that physician care was deemed entirely defensible in approximately 62% of litigated cases. Only 25% involved genuinely indefensible care. But here's the key insight. While defensibility was the primary driver of whether a plaintiff received a payout, payouts in 91% of indefensible cases versus only 21% of defensible cases, the severity of the patient's injury was what drove the initial filing of the lawsuit. Meaning physicians could provide standard compliant, defensible care and still face years of litigation simply because the patient had a bad outcome.
That's the piece that breaks something in physicians who go through this. There's a belief, and it's deeply ingrained from training, that if you practice good medicine, you'll be okay. If you follow the standard of care, if you document well, if you communicate with your patients, the system will protect you. And then you get sued, and you realize that's not how it works. The system doesn't protect you from being sued. It only determines what happens at the end, after years of your life have been consumed by the process. And that realization that doing everything right doesn't make you safe is psychologically devastating. It destroys the sense of control that physicians rely on to function in high-stakes environments.
The average medical malpractice case in the United States takes 3 to 5 years to resolve. Research from nationwide insurer data covering over 40,000 physicians indicates that the average physician will spend 50.7 months, over 4 years, under the shadow of an unresolved, open malpractice claim during their career. For high-risk specialists like neurosurgeons, that figure doubles. They spend approximately 25% of their professional lives with an open claim pending.
The duration matters because it transforms what might otherwise be an acute stressor into a chronic one. and the stress literature is very clear on this distinction. Acute stress, a single event, a crisis, triggers a response that the body and mind are designed to handle. Chronic stress, prolonged, uncertain, and uncontrollable, is what causes the most damage. Medical malpractice litigation is the textbook definition of chronic, uncontrollable stress. During those years, the legal framework traditionally uses what's called a deny and defend strategy. Defense counsel advises the physician to cease all communication with the patient and the patient's family. The physician is told not to discuss the case with colleagues, and in many cases, even detailed discussion with a spouse is discouraged. This legally mandated silence is antithetical to the physician's psychological need to process the experience, seek support, and find closure.
And I want to be really clear about something here, because this is a misconception that causes enormous harm. When your defense attorney tells you not to talk about the case, they mean the specific details, the medical facts, the legal strategy, what was said in depositions. They do not mean you can't talk about how the case is making you feel. You can tell your spouse, "I'm struggling." You can tell a colleague, "I'm going through something difficult." You can seek therapy and talk about the emotional impact. That distinction between case details and emotional impact is something most physicians don't know. And because they don't know it, they suffer in total silence for years. That silence is one of the most damaging elements of the entire process.
Researchers have noted that the emotional trajectory of a physician navigating a malpractice lawsuit closely mirrors the stages of grief originally described by Elizabeth Kubler-Ross. But in this context, the death being mourned is the loss of the physician's untarnished professional reputation, the idealized perception of the patient-physician relationship, and the physician's fundamental sense of autonomy and control.
I think the grief framework is actually more accurate than the PTSD framework for understanding what a lot of physicians experience, because it's not just one traumatic event, it's a series of losses. You lose your sense of safety when you're served. You lose your sense of competence when you read the allegations. You lose your trust in the system when you realize that the quality of your care doesn't determine whether you get sued. You lose your connection to colleagues when you can't talk about what's happening. And you lose your relationship with patients when you start seeing them as potential plaintiffs instead of people who need your help. Each of those is a loss, and you grieve each one differently and at different times, and often without even recognizing that grieving is what you're doing.
The medical literature draws careful distinctions between MMSS and two related conditions: second victim syndrome and moral injury. Sarah, can you walk us through why these distinctions matter?
They matter because the trigger is different for each one, and the trigger determines the appropriate intervention. Second victim syndrome, described by Albert Wu in 2000, refers to the psychological trauma a clinician experiences after being personally involved in a medical error or adverse patient outcome. The trigger is the clinical event itself. The patient is the first victim. The traumatized clinician is the second. The physician with second victim syndrome is primarily mourning a clinical error. They're consumed by guilt about what happened to their patient. MMSS is different. The trigger for MMSS is the legal process. The lawsuit, the depositions, the discovery, the cross-examination. A fundamental insight from closed claims data is that defensibility of care doesn't correlate with whether a lawsuit gets filed. In a substantial number of malpractice cases, physicians provide care that is entirely standard compliant and free of error, yet they still face multi-year litigation. So a physician with MMSS may not be mourning a clinical error at all. They're surviving an adversarial legal attack on their professional identity. Moral injury, a concept adapted from military psychology, occurs when providers are forced by systemic constraints to deliver care that contradicts their deeply held ethical standards. Understaffing, lack of resources, impossible triage decisions. The trigger is systemic betrayal, being placed in an impossible situation by a broken system.
And the reason these distinctions matter clinically is that the treatment is different for each one. A physician with second victim syndrome needs peer support to process clinical guilt and participate in root cause analysis. A physician with moral injury needs systemic reform and acknowledgement of the impossible conditions they were subjected to. A physician with MMSS needs legal education, demystification of the tort process, cognitive reframing, and specialized support to endure an adversarial system that often feels inherently unjust. And here's the thing, these conditions can overlap. You can have an adverse patient outcome that triggers second victim syndrome, which then leads to a lawsuit that triggers MMSS in a system that's understaffed and under-resourced in a way that contributed to the original error, which is moral injury. Physicians can be experiencing all three simultaneously, but if you don't understand the distinctions, you can't target the intervention.
Not all physicians face the same risk. The likelihood of being sued, and therefore the risk of developing MMSS, varies dramatically across specialties. A retrospective analysis of over 18,000 closed malpractice claims in the Netherlands found that surgical specialists accounted for 77% of all claims. The metric researchers use is estimated annual risk, the probability of a physician facing a claim in any given year. The average for all surgical specialties is 21.6%, meaning a surgeon can statistically expect to face a claim every 4.6 years. For non-surgical specialties, the rate is 2.5%, roughly one claim every 47 years. An eightfold difference. Among individual specialties, orthopedic surgery has an estimated annual risk of 28%, a claim every 3.5 years. General surgery, 23%. Obstetrics and gynecology and general surgery have lifetime litigation rates approaching 60 to 63%. Neurosurgeons spend over 25% of their active careers with an open malpractice claim and face median plaintiff verdicts of $2.55 million, rising to over $10 million in pediatric cases.
I practice hospital medicine. My specialty risk is somewhere in the middle, but I want to point out something the data reveals that I think is underappreciated. The G study from JAMA Surgery found that civil legal problems increase suicide risk by 61% in surgeons, but by 80% in non-surgeons. The authors suggested that physicians in specialties where litigation is less common may experience more emotional distress when claims occur, precisely because they're less prepared for it. It's not expected. It's not normalized within their specialty culture. A neurosurgeon who gets sued may have mentors and colleagues who can say, "I've been through this too." An internist or a psychiatrist may not, and that isolation amplifies the MMSS response.
In 2019, Joseph Maroon, a neurosurgeon, published a case report in the Journal of Neurosurgery that documented something unprecedented in the medical literature. Catastrophic cardiovascular complications directly attributable to medical malpractice stress syndrome. The first case involved an otherwise healthy spine surgeon and professional athletic team physician. He was named in a highly publicized malpractice claim. During the multi-year litigation, he experienced severe anxiety, depression, suppressed anger, insomnia, and fear of reputational damage. During the trial itself, he suffered a fatal pulmonary embolism. He died in the process of defending himself. The second case involved another otherwise healthy surgeon, also a professional athletic team physician, named in a similarly publicized claim with prolonged litigation. Around the time of trial, he suffered a non-fatal coronary event and peripheral vascular thrombotic event. He survived, but the cardiovascular damage was life-altering.
I need to sit with this for a moment because I don't think the magnitude of what Brian just described fully lands without understanding the mechanism. And the mechanism is something we teach in medical school but rarely apply to ourselves. Prolonged psychological stress activates the hypothalamic pituitary adrenal axis. Cortisol and catecholamines rise chronically over months and years. That sustained elevation causes immune dysregulation, endocrine dysfunction, and can critically a hypercoagulable state. Your blood literally becomes more prone to clotting. This is an evolutionary mechanism. The fight or flight response includes increased coagulation to survive potential physical injury. But when the stressor isn't a predator, when it's a lawsuit that lasts 4 years, that hypercoagulable state doesn't shut off. And the result in these cases was thromboembolism, a pulmonary embolism, fatal during the trial. This surgeon didn't die from a surgical complication. He didn't die from a disease. He died from the stress of being accused of malpractice. The legal system, the process of defending himself, killed him. And I think every physician who is currently in active litigation needs to understand this. MMSS is not just a psychological condition. It is a physiological condition with potentially fatal somatic consequences. You are at elevated cardiovascular risk. That's not an opinion. That's the pathophysiology.
The psychological scars of malpractice litigation do not resolve when the case closes. Longitudinal studies show that trauma-related symptoms persist for decades. While acute anger may slightly diminish over 10 years, fundamental alterations to self-identity and ongoing physical impacts appear to worsen or cement themselves over time. Over half of all sued physicians experience vivid memories of the trauma indefinitely, and a third harbor long-term psychological scars consistent with clinical PTSD. Vizcaíno-Rakosnik's data reinforces this. There was no statistically significant difference in psychological impact between physicians with open claims and those with closed claims. The case closing doesn't turn off the distress.
This is something I think most people outside of medicine don't understand. There's an assumption that once the case is over, especially if you win, it's over. You move on. But the research says otherwise, and if you talk to physicians who've been through it, they'll tell you it changes you permanently. The way you see patients changes. The way you make clinical decisions changes. The level of trust you place in the system changes. And for some physicians, the confidence never fully comes back. They practice for the rest of their careers with a layer of fear that wasn't there before. That's the long-term cost of MMSS that the legal system doesn't account for and the medical system doesn't address.
Michael, this is a lot of difficult information. What should physicians do with it?
5 things, and I want to be specific because vague advice doesn't help anyone at 2 a.m. First, know that MMSS exists. That might sound too simple to be useful, but it's not. The most protective factor the literature identifies is pre-litigation awareness. Knowing what to expect, knowing that the emotional response is normal and predictable, knowing that it has a name, that knowledge is genuinely protective. If you're a physician and you didn't know about MMSS before this episode, you do now. That's not nothing. Second, talk to one person. Identify one colleague, one mentor, one friend, someone you trust, and tell them, if I ever get sued, I need you to check on me. Not to discuss the case, not to give legal advice, just to check on you, to ask how you're doing, to make sure you're sleeping and eating and not isolating. The literature consistently shows that the silence is what amplifies every symptom. Breaking that silence, even with one person, is therapeutic. Third, understand the distinction between case details and emotional impact. When defense counsel tells you not to discuss the case, they mean the specifics, the medical facts, the legal strategy, what happened in depositions. They do not mean you can't tell your spouse, I'm really struggling right now. They do not mean you can't see a therapist and talk about the anxiety and depression. This is the single most damaging misconception in MMSS, and it's the one you can correct right now. Fourth, know your malpractice policy. Read it. Understand whether you have consent to settle rights. Understand what gets reported to the National Practitioner Data Bank. Understand the timeline. Do this now before you need it. because trying to learn the legal landscape while you're in the middle of a crisis is like trying to learn pharmacology during a code. It's too late. Fifth, recognize that defensive medicine is a symptom, not a solution. If you've been sued and you find yourself ordering more tests, avoiding certain patients, or practicing differently out of fear rather than clinical judgment, that's MMSS manifesting in your practice. Name it, address it, talk to someone about it, because defensive medicine doesn't make you safer. It makes you worse at your job and more miserable doing it.
Medical malpractice stress syndrome is a real, well-documented occupational hazard that will affect the majority of physicians at some point in their careers. It manifests as a form of PTSD, with psychological, somatic, and behavioral consequences that can persist for decades. The process of litigation, not the outcome, is the traumatic stressor, and in rare but documented cases, it can be fatal. This was part 1 of our 3-part series. In part 2, we'll explore the connection between MMSS and physician suicide, the silent crisis that claims 300 to 400 physician lives every year in the United States. And in part 3, we'll talk about what you can do before you get sued to protect yourself, your practice, and your health.
Here's the bottom line. You are going to get sued. The statistics make that almost certain, and when it happens, it's going to be one of the hardest experiences of your professional life. But it doesn't have to be the loneliest. Knowing about MMSS is the first step. Talking about it is the second, and we're going to keep talking about it.
Until next time, this is the Charted Defense. Thank you for listening.